Okay, just wanted to make sure. Thank you. You can call me doctor if you want. I'll claim that title. Thank you so much for coming. I really appreciate it. There's just a few things that I want to tell you just personally about myself, and then just for your questions, because last year I was here and we had a lot of questions with regards to the VA and the benefits and so on and so forth. So I'll explain a little of that to you before I start so that when you do ask your question, if it's geared toward that, you'll know how to word that question. But Angela Griffin, and I'm a proud mom. I just had a baby. I've been back from maternity leave. She's 4 months now. And so I just got back to the VA and they were like, we need your PowerPoint. You got to do the presentation. And I'm like, okay. So I had this last year. I tweaked it a little bit to provide more information. I did remember some of the questions from last year that I was able to put on here. So it'll be able to help you further if you were here last year and you still had some of those same questions. I have been at the VA for a couple of years now. And again, prior to that, I was at the state of Michigan working with criminally mentally ill patients at Walter Reuther Psychiatric Hospital. I'm an athlete. I play women's professional basketball and football. And I'm actually a part of a team called the Detroit Demolition. I don't know if you've heard of it, but we are 5-time champions. So you are looking at the first MVP of that league. Thank you. So I always tell people, don't let these heels fool you now. Something deeper. No. My husband thought I was too prissy, of course. And then when they announced me as the most valuable player, I said, who's prissy now? So I'm really proud to say that. And I have 2 little girls, a 3-year-old and now a 4-month-old. And she woke up for the first time out of she sleeps throughout the night. And last night she woke up at 2:30. And I'm like, what in the world are you doing up? But she's great. So just to give you some information and history let me just tell you about the learning objective. They make us put this on here. But anyway, we're going to learn about the scope of the problem of suicide among the veteran population, the national efforts on suicide prevention, the roles of the suicide prevention coordinator, and we're going to also look at some of the signs and symptoms of suicidal thinking. And there's another thing that we're going to look at that I added at the end of this is really called a safety plan. We're going to kind of learn how to do a safety plan. That's really important in an evidence-based tool. And we're going to start off defining suicide. A lot of people have a misunderstanding of exactly what suicide is, and they only have one definition. It's either a completion or an attempt. And there's a few different definitions. Of course, suicide is an attempt. A suicide attempt is defined as a potentially self-injurious behavior with a non-fatal outcome, where there's evidence that the person had intent. And I put that in red because intent is one of our main risk factors when we talk about if they have means, plans, and intent. When we're interviewing people that have attempted suicide. We talk about completion. We know that is a fatal outcome, death from a self-inflicted injury, poisoning or suffocation, where there is evidence that the act was intentional. Undetermined suicide is a self-inflicted injurious behavior where the intent is unknown. And an example of that is, say for instance, someone is suffering from pain. And they're trying to ease some of their pain, but at the same time they may be suffering from a little depression, and they decide to overdose on some Vicodin. And then, so they're now a little in a different state of mind, and they may take some alcohol and other pills, and it may lead to an undetermined suicide or undetermined suicide attempt. They may have survived it, so we call that an undetermined suicide attempt. When the intent is unknown and after the person is conscious, we may get more information, but at the same time, they're at that teeter-totter. I was in so much pain, I did think about killing myself, but I really didn't want to die. And so their intent really is unknown. An aborted suicide attempt is a potentially self-injurious behavior with evidence that a person intended to die, but stopped the attempt before damages occurred. And of course, an ideation is the reoccurring thought of suicide. It may vary in its seriousness depending on one's specificity of suicide plans and the degree of its intent. Again, we're talking about the degree of its intent. We're talking about their plans. Now, this was sent down from our central office. And this is what we use, and you'll hear a little bit more about what we do as a suicide prevention coordinator. A little bit more. Did my mic go off? Oh, okay. Okay. So you'll hear a little bit about how we use these definitions when we have a veteran that comes into our department for one or the other. We're going to talk about the challenge. You've heard, of course, suicide is the 11th leading cause of death in the United States, taking the lives of over 32,000 people each year. It outweighs homicide. In 2006, there were 162,000 individuals were hospitalized for self-inflicted injuries. And in 2005, 372,000 plus were treated in the emergency room for self-harm. The primary risk factors were suicidal thoughts and a history of those behaviors, psychiatric diagnosis, depression, bipolar, substance abuse, physical illness, pain and functional impairment, availability of lethal means such as medication or firearms. And we are at the VA, we are in our Vietnam, where a lot of the veterans that come to the VA now are Vietnam veterans, and a lot of them are taking the medications, and so the availability, those medications are available to them a lot more accessibly. Feeling of hopelessness, impulsivity, aggression, and anxiety. And elderly white males are at a higher risk, especially when alone. And I'll share some examples with you from the VA that we've had recently. Suicide in the veteran population. Male veterans are twice as likely to commit suicide of any gender. 1,000 suicides per year and 5,000 among all living veterans. Now, those statistics were actually given to us prior to there being suicide prevention coordinators at the VA facility. So there is a change in this data. 30,000 Americans die by suicide each year. 90% have a mental illness. Who can tell me what they think that mental illness is? Depression. And believe it or not, 80 to 90% of people that suffer from depression actually respond well to treatment. 60% of those suicide completions were diagnosed with major depression. Death from suicide outnumber homicide, and it's the 11th leading cause of death in America. 20% of all suicide occur in the veteran population. That's a big percentage because our veterans make up a small percentage of our population. I think it's about 0.1 a percentage of our population. So 20% of all suicides in America occur in the veteran population, and we're going to find out why. Because earlier I had said they are twice as likely. We're going to find out why they're twice as likely. How many veterans do we have in the audience besides the obvious? Okay. 90 to 95% have a diagnosable mental illness. 60% who die by suicide suffer from depression. 80 to 90% respond to treatment. 60% of all suicides occurs on the first attempt. And 50% of those who attempt will reattempt the same year. 10 to 20 of those will have a completion. 80 to 90% or 70% communicate their intention. We're going to talk about some myths and misinformation also, because a lot of people think, oh, they're suicidal, they're going to do it, there's nothing I can do about it. We're going to talk about some myths and misinformation with regards to suicide. 80 to 90% actually see a physician within 1 month of their attempt. That's their primary care doctor, and I'll explain to you how now we are communicating mental health and primary care. It didn't really communicate a lot. And now we're communicating a lot more collaboration with regards to our veterans that we call are high risk for suicide, and I'll talk about that more. Individuals age 65 and older account for 16% of all suicides, and 75 is nearly 6 times the national average. 1 out of every 4 suicide attempts for men over the age of 60, there is a completion. So 1 completion for every 4 attempts. That's alarming, really. Of those who attempt suicide, again, 10 to 20% will make an additional attempt within 1 year. Veterans are more likely to use firearms. 60% of our veterans suicide death involve a firearm. I'll tell you a really brief story. You'll hear me interject stories here and there. We had a recent suicide at our VA, and a young lady came in, and we have what we call a code silver. That's, let them know they have a weapon. So she kept asking our physician, aren't you going to call a code silver? And the physician's like, why? Do you have a gun or a weapon? And she didn't really answer. And so just knowing this veteran, she had been involved with the VA services for years, a victim of sexual assault within the military. She suffered from military sexual trauma. And so they decided to commit her to the VA. And so she walked with our physician down to our chief's office. He's a chief of mental health, so that he can do what we call a cert and petition and cert. So he can, have the papers to commit her to the hospital. And this individual said, I am not going to be committed. She pulled out the gun and shot herself right in his office. So women veterans are likely to use a weapon as well, because they're trained in how to use a weapon. And a lot of them know exactly what to do. I had one veteran tell me, it wasn't an accident that I didn't complete this, because if I really wanted to kill myself, I know exactly how to do it with my weapon. I was trained in special forces, so I know how to do it quietly and quickly and really less painfully. They are very much trained. An average of one person every 15 minutes, this is the recent 2006 data that I pulled from the CDC website. 15.8 minutes, someone kills themselves. And as Dr. Crosby was indicating, as we're sitting here, as we're speaking now, we've been here for a couple of hours. There have been a number of completions throughout. An average of one elderly person every 1 hour and 32 minutes kill themselves. 1 hour and 32 minutes. I speak here for an hour and 30 minutes. An average of one young person every 2 hours and 5.5 minutes kill themselves. 832 plus annual attempts in the U.S. translates to one attempt every 38 seconds. 25 attempts for every death for suicide for the nation. And 3 females attempts for every male attempt. Sobering data. About 50% of the people who commit suicide see a healthcare physician within 30 days prior to their attempt. A lot of people within our, outside of the mental health, think it's just a mental health issue. And as Dr. Crosby said, it is an issue, it's everybody's business. Suicide is everybody's business. I was at the VA, and I was walking down the hallway, and one of our elderly veterans, he looked a little lost. So I said, well, can I help you, sir? Well, I just left my primary care, and I told the nurse I was going to go home and blow my brains out, and she sent me down here to the mental health, and I can't find it. And I said to myself, first of all, what is he doing walking the hallways by himself? And second of all, I said, well, you ran into the right person. You didn't know who I was. And so I led him to mental health. We got him some treatment. He was hospitalized for a while, and so he calls me his angel to this day. And he is doing well. And remember, in the statistics, it said, especially when alone, he had no family members, no children, never been married. And his closest relative was in Canada. So we know what we have to do to go over to Canada now. So he had no one. It was just him, and he was suffering from pain. So suicide prevention. The VA has now, in 2 years, a little over 2 years, decided that they want to get involved in suicide prevention amongst our veteran population. And how did they go about doing that? What was the reason for that? Well, there was a veteran called Joshua Amvig, and he suffered from post-traumatic stress disorder, acronym PTSD. And he was deployed, suffered from, his family said that he was withdrawn, started engaging in risky behavior such as drugs and alcohol, and he was very isolative, really didn't talk much, and they just thought, oh, he's just going through some things when he came back, he's got to get adjusted. They didn't know the signs. And so one day he walked out the house, and his mother said just something wasn't right. And so she ran up behind him, and he got in his car, and the moment he got in his car, he pulled out his gun and shot himself. And she didn't understand. He wasn't involved with the VA system. They didn't know how. And at that time, the Department of Defense and the VA weren't quite communicating very well. And so the senator in Iowa fought for Joshua Armvig bill. And when this bill passed is the reason for my position at the VA. And his bill says staff education, carrying out comprehensive program under this section, mandatory training for appropriate staff and contractors, including all medical personnel. So my job at the VA, and you'll find a little bit more, I do a lot of things there, is to educate the staff, especially non-clinical staff, on some of the warning signs of suicide within our VA population. And it is mandatory for them. The one thing that also came out of that, and the Blue Ribbon panel we'll talk about a little later, is now they have suicide prevention coordinators at every VA facility. Can you see? Am I in your way? I'm sorry. Can you see this? Okay. We have 156 or 3 VA medical facilities, and there are 1 suicide prevention coordinator at every facility. We just recently got some help, and I'm really excited. At the table that we have, I have a case manager now, and she's at the table. And so we also have a support assistant who's not here. So I do have a team of people now, and I'm really excited about it because it allows me to do so much more. I think they really underestimated what we were supposed to do. And so when they saw our face and name and title at the VA, we was like swamped with everything, and we're like, oh my gosh. And so we're still kind of, going through and sorting things out. And it's been a tremendous help for a lot of our veterans at our VA. We have a 24-hour hotline. At the end, you'll see Gary Sinise, and he'll talk about the hotline. And that's a national hotline. I believe in May of this year, we had over 300,000 calls to that hotline from January to May, just that short period. And a lot of them were veterans, a lot of them were non-veterans. And if you press 1, it'll get you directly to a someone who specializes with the veterans. And what that call does, if the veteran is going through a crisis, once they take the information, they may do a rescue. They may do, they may do a well-being check, sending a police officer out to the home just to check on the well-being. They actually had, I can't remember the data, I'm sorry, coming back in 3 weeks, there's so many numbers up here, but we had an alarming number of saves from people who called the hotline and said, I just overdosed and I realized I didn't want to die, and I'm not in my mind now, and they were able to get some help out to them and save their lives. The one, I remember a story where the person was on the phone and he would call the hotline, but he was in the cemetery with a gun and talking to her saying, I just want to say goodbye. And one thing, he called the hotline, so that was sent a little message, and she knew that. And he wanted to say goodbye, but he really didn't. And so she was able, he had GPS in his phone where they were able to track. And so we have caller IDs on our phone. And so she was able to get his location, and the police officer met him out there, and it was just a wonderful, it was such an emotional story. And I think she was just like, oh my God, I can't believe. But the hotline is located in Canandaigua, New York. So if anyone called that number, it goes to Canandaigua, New York. What will happen is if someone in my area, Dearborn, Detroit, sometimes Ann Arbor, Southfield, or whatever, call, they will send me a consult through my computer and say, a veteran in your area called the hotline. We need you to make contact with them, okay? And so we'll call and check up on them, and sometimes they just want to vent. Oh, I'm glad they were there. I just wanted to vent, so I'm okay. And so we're like, well, come on in for some services and some treatment, and we'll go from there. So that's what that hotline is for. Guide training is the training that I do with the staff to inform them on the signs and warning signs of suicide. Ongoing identification of patients at risk. You'll see a slide where it talks about central office identified. Who is high risk? I think when I first got to the VA, they were saying, oh, he's thinking about suicide. 10 years ago, he had a suicide attempt, and he came in and said he was thinking about it, and they were like, he's high risk. And I'm like, well, 10 years ago, and that's a little bit much. He's survived 10 years. So we were like, okay, we need a good definition of what is high risk, okay? And you'll see, and I'll define it as we go along. So we have a high risk identifier, And those veterans that meet that criteria are placed on our high-risk list, which means that their chart is flagged. We have a computerized chart. So I can go on my computer, put in a name, and his chart will come up. Everything in his chart, medication orders, everything in his chart is computerized. And when the chart comes up, they'll see a suicide flag. And they're like, oh my God, okay, he's high risk for suicide. So that they know how to better assist this veteran. A lot of times they go to our primary care department, they're suffering from some symptoms, but because they're not aware of those symptoms, they just kind of say, oh, okay, well, you know, if you need some help, go over to mental health. And then there we go. Like this gentleman, I mean, this was obvious, but he was, you know, 89, I find out, and he's walking alone in the VA. But had his chart been flagged, then maybe somebody would have called down to our mental health department to come meet him and ER, and then we would have been able to handle the situation a lot better. But thank God he ran into me, and I was able to get him some help. Access to mental health services. We have an ER. It used to be called urgent care, but now we are an ER department, and they can access that 24 hours, 7 days a week. We have a trained mental health provider on call. So if you come in for suicide ideation or an attempt, you are evaluated right then and there by our primary care, by our mental health provider, and then assess whether you need hospitalization or any outpatient treatment. Monitoring and follow-up to maintain continuous care. That high-risk list, we follow them. They're not our cases. They're actually the facility's high-risk list. But if they miss an appointment, we want to know, okay, are you okay? So we make a phone call. Sir, you know, you missed your mental health appointment today. I need to make sure things are okay with you. Oh, yeah, Mrs. Griffin, I just had car trouble, but I called and I'm going to reschedule. And okay, well, you know what I can do? I can transfer you down to your provider's office and you can reschedule right now. Trying to stay connected with services is our goal, and we've learned that evidence-based, that is a very good tool to use, is to make sure that we are in continuous contact with them. And I've had so many veterans call, Ms. Griffin, you have no idea this call, how much this call means to me. I don't know what they're doing, but they're like, this call means a whole lot to me, and I really appreciate it. Thank you so much. And then they're talking, and it's been a really good tool. I talked earlier about the Blue Ribbon work group, and we're like, what is that? Well, former Secretary James Peake, they wanted to know, okay, suicide in the veteran population was increasing, and they weren't equipped to deal with it. Okay, in 2006, the numbers they were just going out of this world, and they were like, how can we deal with it? So he got a group of individuals together so that they can give him expert advice on what kind of strategies to use within the VA system to help decrease the number of suicides. And that's what this blue panel, and you'll see some recommendations. They had 8 recommendations. Finding one was conflicting and inconsistent reporting of veteran suicides. Everybody saw the news media, right? They said the veterans, they're lying, okay. Well, the recommendation was establish an analysis and research plan in collaboration with other federal agencies to resolve conflicting studies, okay? So now what we do is we have 2 systems that we work with. We have the suicide behavior report for any suicide that is any attempt or completion. Whoever is first aware of this fills out that report on the computer. I get sent an alert. I send that information to central office. That's how they're keeping their data. The other one is an attempt and completion report. So when they fill out that suicide behavior report, I tally it up on this attempt and completion report, and it gives us information, the age, gender, whether they're OEF, which means our Operation Enduring Freedom, Operation Iraqi Freedom veteran. That's our returning veterans now, so you'll hear me use that acronym interchangeably. So our OEF, OIF, are they Gulf War veterans? Are they Vietnam veterans? And what were their age? Or are they substance abuse? Are they a mental health patient? Were they last seen at the VA in 10 days, 7 days, 30 days? What were their pain score? So we're getting all that information and we're sending it up to them so that they can further do research on how we can prevent this. Now, ironically, they did it for the OEF, OIF veteran because of the increased rate. But on my high-risk list, we have maybe 37 people on that list. Probably 7 of them is OEF, OIF, and the remainder of them is Vietnam veterans. So this service has really been more available to our Vietnam veterans than our OEF, OIF. And then, you know, you hear, well, we're OEF, OIF. We don't want to be involved with the system when we come back. We just want to go home and get our lives together. And then you realize 6 months to a year later that they really need some help. And so then they start coming in. And hopefully they don't have comorbid, you know, they don't have now substance abuse issues and any other issues on top of possibly PTSD or anything, because then you have to treat that before you can ever treat the PTSD. Finding number 2, screening process. Recommendation is we should revise and reevaluate current policies regarding mandatory screening. So now, I have a lot of work to do. But now I just came up with, we have a clinical reminder. So now a veteran goes into any non-mental health or specialty or ambulatory clinics, podiatry, you know, women's clinic, if they have a flag on their chart, they have a clinical reminder, which is a little tool that pops up and says, you need to ask about suicide, current suicide, okay? And so they ask these little few questions and it goes into their chart. So they're screening now more in our non-specialty clinics because, again, remember, 50% of them attempt 1 month while, you know, after they've seen their primary care doctor. Finding number 3, attempting to systematically provide coordinated intensive enhanced care to veterans at high risk for suicide and being flagged as high risk. And that's what we do. We put flags on their charts. It's a category 2 flag. So that means that only people, and I'm going to use some terms, VISN, Veterans Integrated Service Network, right? VISN, yes. Okay, what that is that we have 153 medical facilities where each of us are in a little group called a VISN. So we have Battle Creek, Indianapolis, Indiana, Danville, Illinois, Detroit, and Ann Arbor. We're all considered a VISN. So we can only see that flag within our VISN. But if they move to New York, they're not in our VISN, they can't see the flag. So we have to be in constant communication with them. Are you moving? We had a veteran who recently moved to North Carolina. I had to contact the North Carolina Suicide Prevention Coordinator. He's moving to your area. He is flagged for suicide. He's up for a reassessment. Can you please monitor him for an additional 30 days and then reassess? And we're really quick. Oh, yes, Ms. Griffin, I got that, and he'll be here. And so we give them the name and the information, and they go from there. Okay? Another, root cause analysis. Root cause, we call it RCA. Presented to the work group did not distinguish between suicide death attempts and self-harming behavior without intent to die. So we ensure that suicides and suicide attempts that are reported from root cause analysis use the definitions. Remember the definitions that I had at the beginning? We use those definitions. Okay, so we do a root cause analysis, which means that we need to find out what the VA could have done differently to prevent this. And what can we do now to be more proactive? Number 5, leadership. The use of clozapine and lithium does not appear to be sufficiently evidence-based. So we are now finding to ensure that pharmacotherapy recommendation related to suicide or suicide behaviors are evidence-based. So they're finding research on different medications that are helping. We found that in the smoking cessation group that Chantix, which is a new medication to help cease the craving for smoking, causes suicide ideation. So you don't want to give that to someone especially flagged for high risk for suicide. That's another benefit of that flag. So efforts to improve media coverage and disseminate universal message to shift normative behaviors to reduce population suicides. Risk behaviors are not being fully pursued. Continue to pursue opportunities for outreach to enroll eligible veterans to disseminate messages to reduce risk behavior associated with suicidality. My job is to also do community trainings. I'm involved with this coalition, of course, with our hospitals. We're located in the cultural center, so you got the hospitals all over. So I'm involved with them because veterans, they don't want to come to the VA half the time. They want to go somewhere where you're not seen. So they go over to Detroit Receiving Hospital, and so they'll call me and say, a veteran was over here, he attempted suicide. And so we send that information up as well. Then we contact him and say, okay, you was at Detroit Receiving. Do you want to get transferred over here to the VA system? Sometimes they do, sometimes they don't. Concerns about confidentiality for the OEF, OIF service members treated at VHA service facilities. The issues of confidentiality of health records of the OEF, OIF veterans who receive care through the VHA, Veteran Health Administration, should be clarified for both patient consent to care and for general dissemination to reserve and guard service members contemplated utilizing VHA medical systems. Well, basically what that's saying is that we have an OEF, OIF outreach worker, and she goes out to these to the OEF, OIF, and hopefully bring them back to treatment. A lot of them don't want to come to treatment, so she treats them in their home, and she provides services to them in the community. And number 8, the coordinators, and that's who you see right here in front of you. To maximize the effectiveness of suicide prevention coordinators, we have ongoing evaluation of our roles and our workloads, and so we were deemed with so much that they approved for case managers. So they're going to continue to reevaluate, and hopefully we'll get more assistance. You know, my goal is to get a psychiatrist and a psychologist and a nurse in our program so that we can keep everything in our program. So if a veteran comes in for suicide attempt, they say go up to the 3rd floor, and we have right there a nurse, we have right there a psychologist or even a physician to right away assess them, and a psychologist to provide the counseling possibly, and the social worker case manager to provide the case management services. And then, of course, me will continue to do the coordination. So my responsibilities, based on all of that, is to promote awareness about suicide prevention, include our guide training, which is in a form of an assist training. How many of you had assist training? Well, we call ours Operation SAVE. So SAVE stands for Signs, Activate, Validate, and Implement. Okay? I mean, S-A-V-E. Yeah. So those are, it's very similar to the guide training. We just call it the Operation SAVE training. Assist the facility in identifying those who may be at risk. This is actually very difficult. This is, believe it or not, it is very difficult. Because when you hear the word suicide, people are like, oh, Lordy, you know, that little church, excuse me. And they say, we have a coordinator, go send it to Mrs. Griffin. And you know, what I try to get around to the hospital is that it is everybody's business. You need to learn how to assess for suicide. Our guide training is for non-clinical individuals. And I've had more non-clinical individuals come up to me and say, I had a veteran on the phone, I did everything you said, and he came in, and I'm so proud of myself, and yet, you mean, and so they're utilizing these tools, and sometimes we get that extra letters behind our name, and we don't want to do anything else, except for what our title says to do. You know, I don't like dealing with suicide, so, you know, we got a coordinator, we give it to her. Assist in a national tracking and trending program so that we can learn more about these veterans. And that's where the attempt and completion report comes in, the suicide behavior report comes in, so that we can assist in tracking these veterans. Assist in identifying those veterans who have attempted suicide, working with our patient safety team. We have a patient safety coordinator at the facility. Her job is just to promote patient safety throughout the hospital. I am also involved in the environment of care, which is part of patient safety. So on our inpatient unit, my job was to assist in identifying some barriers for safety for patients at risk for suicide. So I'm just going to ask you guys a couple of questions. How many see some anchoring, some anchoring points in this room? How many anchoring? Yes. You can use. Yeah, no, a sprinkler system, it's going to break. He said, no, Mrs. Griffin. This is one of the engineers. You know, this is where their specialty comes in at. He said, our pipes are routed throughout the hospital where they're all connected so it can actually hold the weight of 2 or 3 individuals. And I was like, oh, well, I didn't know that. But, you know, a door handle, if this was a different door handle, and people don't realize a door handle, you can actually commit suicide on a door handle. I was like, it's way down here. Okay, well, you can actually tie it around and lean forward, and you can actually kill yourself that way. There's a lot of anchoring points. So my job is going to assist in our on our inpatient unit to abate those items. So we've had a whole reconstruction on our inpatient unit, and they didn't like me very much. Mrs. Griffin, are we going to ever get back on the other side? I'm like, well, it's not up to me. They're coming down with different things every day. How many know what you can do with dental floss and a plastic spoon? Okay. Are you familiar? Okay. We had, only one veteran got this, and this is one of our OEF veteran in one of my trainings. And what a veteran did on one of the inpatient unit, not our hospital, so don't be going around, oh, on Detroit Hospital, that lady told me. It was somebody else. But what they did with the spoon is they took the spoon, the handle, they took the dental floss, and you know the little metal thing where you clip the little dental floss off? They put that up the spoon, and they took the dental floss and wrapped it around. Now what do you have? Cutting tool, a shank or whatever. And he used that to cut this artery. And so now we have to minimize the use of dental floss or monitor now dental floss on our inpatient unit. So we had to, you know, the toilet sometimes they have those pipes exposed. Well, that was an anchoring tool. So we had to cover up those pipes, and we had to use breakaway shower curtains. And we're still working on our anchoring systems on our doors, because if you anchor the door this way or you cut it, then it's no longer used as an anchoring point. Well, we're still working on that because they don't want to cut our doors. Brand new doors, cut them. But that's only used for new units, so we don't have to do it. But those are all kind of things that we are doing in our VA system to abate items for suicide. The hotline I talked about, community outreach I talked about, contact and monitoring of the veterans I had talked about. Now the case manager does that part. She contacts them. Follow up on referrals. And let's see. After every training, and it's never failed, after every single training that I do at the VA system, I have somebody come to me, 2 or 3 people come to me afterwards, and they tell me a heartfelt story about either their survival or a family member or someone that they knew who attempted suicide, and that how much this training meant to them. Maintaining the high-risk list. Make sure that we call them and follow up with care and services. Assessing the risk of suicide. Okay. Contact veterans who have been identified as surviving an attempt, and also it's my job to contact the family members of a veteran who have completed suicide. We had a speaker the other day. This is Suicide Prevention Week at the VA, and we had a family member, an OEF parents. He was 24 years old, and he shot himself right in the presence of his mother, and he kept telling her, you know, God said, take you with me. And she's a nurse, but she said, Mrs. Griffin, that nurse didn't, she said, that mother mode kicked in, and I'm like, you sit down. You know, she said, I'm trying to treat him like a little kid. Now you sit down, you listen to me. And no matter what she did, he had his mind made up, and they are devout Christians, and so she blamed Satan for, you know, trying to invading those thoughts. And she said that when she picked up the phone to call 911, he walked out the door, and as she began to dial, she heard the shot. And she went outside, and she automatically, nurse mode kicked in. And she said, but I saw the life of my son, just the life leave my son. And she came up, her and her husband came up to speak at our facility on Thursday, and it was an overwhelming response from our VA, and it was the support for her and her family, and it was really great. So my job is to contact them to find out what happened. He was not involved in VA system. She said she tried to get him involved, but he refused. So it's really important, if you know a veteran that comes to your facility or comes, you know, to get them involved in the VA system. If not, make sure they're involved in your, you know, treatment or your system. This is a high risk that I said that we'll identify who is at high risk, okay? And our National Central Suicide Prevention Coordinator, which is Jan Kemp, she's over all the coordinators, sent down this definition. High risk for suicide, a variety of reasons. It is a clinical judgment, and people are, actually we are afraid to make clinical judgment. I'm finding that out the more and more I'm at the VA. We are actually afraid to make a clinical judgment. you know, our chief thought he was making a good judgment. And even though the young lady killed herself, you know, that was a clinical judgment to hospitalize her. But we are afraid to make clinical judgments. And after evaluation of risk protective factors and risk factors and the presence of warning signs as listed on the pocket card that we have at our table, we have this little pocket card. Because our veterans are transient, we try to get little pocket cards for them to recognize some of their warning signs, and they can carry them everywhere they go. So they're little pocket cards you can put in a wallet or a little pocket. So these are what we consider high risk. Recently hospitalized, a recent attempt, threatening to kill themselves with a plan, with the means, with intent. My name is John. I'm here. I have a gun, and I'm going to kill myself. You know, he has a plan, he has a means, and he has the intent. Looking for ways, hoarding pills. We now have a 14-day medication restriction for veterans to reduce the risk of overdose. And we're not trying to isolate them, but what we're trying to do is just make sure that whatever we can do to reduce the means, then we can do it at our VA facility. I hope y'all can see that red. That was my fault. I thought it looked cute. But what we talked about earlier, I said that veterans are they're twice as likely to commit suicide as non-veterans. And we're going to talk about why. General factors that you and I may go through. We're talking about self-harm and previous attempts and alcohol or substance abuse, poor self-control, history of abuse, recent loss, recent discharge. Why would that be a risk factor? Recent discharge from a hospital or group home? Life-changing. You know, on our inpatient unit, they get 5 meals a day. They have their wheelchair down to all their appointments. They get their dental care. They get their feet scrubbed, you know. They have their buddies on the unit with sharing war stories and that socialization. And then now you're going home to the situations that may have caused you to come in the first place. And so they're lost. And so our job is to contact them immediately after discharge. Hey, I heard you were just discharged. You doing okay? And so we make sure that they come in for their follow-up appointment. Now, veteran-specific risks. Yeah. Demographic factors. White men over the 70 years of age are an increased risk. Why would that be? They've always been, and you know, as you get older, you don't recover as quickly, you know. Frequent deployments. Now, these are veteran-specific risks. This is the reason why they're twice as likely, because they engage in the general risk factors as well as these. Frequent deployments. I had a guy that had 5 tours in Iraq. 5 tours, completely psychotic. You know, I'm talking to him over the phone, and he's hearing voices, auditory hallucinations, visual hallucinations, and you know, my job was not to tell him that he's not hearing these voices. I just wanted him to focus on my voice. Okay, don't listen to those other voices, sir. Listen to my voice. And it took me 40 minutes. And some people are like, 40 minutes? Yes, but it saved his life. And I'm so happy that I was there, you know, to do that. That's because the VA, I was only there 3 months. I'm like, what did I get into? They didn't transfer the call down to me. I'm like, hello. Deployment to hostile environments. We had a guy that was guarding the gas lines in Iraq. He broke down in the middle of war. They had to rescue him out. He was turning on his platoon. And when he got to the VA, you can still see him. It's almost as if he was still in combat. He was shaky. He was red. And as you began to talk about it, he just began to get a little bit more anxious, more angry. One guy said that his best friend, they were walking, and his best friend was hit by a sniper. And so he looked over and he just brain matter everywhere. And so he's, you know, went on a killing spree. He just started shooting up everybody, shooting at everybody. 23 years old. And he came back. Of course, he's no longer able to have a weapon. He had a criminal record. And so his thing is, what do I do now? I'm over there fighting for my country, and yet alone I can't even come back here and get a job. I can't even carry a weapon. I want to go back. His whole thing to me is, I want to kill some more. I want to kill some more. And he was really, really serious about it. Exposure to extreme stress, physical sexual assault while in the service. Again, this young lady suffered from military sexual trauma. We do have a military sexual treatment program now at the VA. We had a young man, it says not limited to women. We did have a young man on the high-risk list that was gang raped while he was in the service. And he, how many know suicide by cop? What is that? Intentionally to make you shoot. My husband's a state trooper. All right, don't be using his name when y'all get pulled over. Tell him some, what was that lady name? Griffin, he's my uncle, you know. No. But, you know, his thing is, you know, you see a gun, the first thing you are aimed to do is shoot. You don't wait to see, is that a water gun? So he was engaged in suicide by cop. Thank God the cop did not shoot. But he was engaged in suicide by cop, jumped off of a bridge. You know, like, how many of you are familiar with the Lodge Freeway in like 94 area over there? He jumped off of that bridge. Also jumped out of a moving car 60 miles per hour, engaged in risky behaviors. He was provoking a drug dealer to kill him because he said, I stole his drugs because I wanted him to kill me. I knew he was going to come looking for me. So I wanted to steal him, and I was waiting for him. And I kept saying, shoot me, you know. And lengths of deployment, the 5 tours. Service-related injury, pain, an amputee, TBI, traumatic brain injury. Risk factor, we're going to talk about some biopsychosocials. How am I doing on time? I'm sorry. I'm okay with time? Okay. Thank you. Mental disorders, particularly mood disorders, depression, bipolar, schizophrenia, personality disorders, substance abuse, impulsive or aggressive tendencies, trauma. Okay, we're going to kind of go through some of these. Environmental, some of these veterans, they can't find a job when they come home. You know, you left home, you know, and come back, and now they can't get employment. Okay? Lack of social support. We don't understand. I'm not a veteran. It's hard for me to understand, oh, yeah, I can understand what you went through in Iraq. No, I can't. It's hard to get that social support. The stigma associated with seeking help. I'm a veteran. I'm here fighting my country, fighting for my country, but yet I have this little dark hole in me, and I don't want to get help. People are going to think I'm crazy. And you know, they even, I talked to someone in the, that does the evaluations when they get into the Army. They took off the question, do you have a mental illness? They took it off. They took it off, have you ever was engaged in mental illness or any services related such as that? They took it off because they found out that people were fibbing, and when they went to the service, and after engaging a little while, they realized, okay, you do have a history. So they say, we just took the question off. They don't even ask the question anymore. Barriers associated with accessing health care. We now do post-deployment, so we have a welcome home for our veterans next Saturday. Hopefully you can come out to the VA to support that. We have veterans coming home. We're welcoming them home. But we also have post-deployment, which means when they come home, we have a team go out and meet them at Selfridge Air Force Base and register them right there. We don't let them go anywhere. We register them right there. We get them involved in services of treatment. They're screened, and whatever they come up a positive PHQ-9, that's a depression screen, we're getting them treatment and services right there. Religious beliefs, exposure through the media. We all know what the media does. Don't listen to the media. What our vets are exposed to. Leaving all that is known to them. 23 years old, leaving. We are still young. I was just still in college playing ball. You know, I'm like, talk about leaving home to go fight for a country. Constantly living with the fear of unknown, loss and grief, leaving your children, your wife, adjustment. I really don't even know how I did this. You know how it just pops up and down? I must have hit a button, so excuse me. Combat, sleep deprivation, guilt, fear, hypervigilance, stimulation of senses. We have all of these that our veterans go through. Return to civilian life. Okay, I went over there and shot people. One of the poems, a poem that the veteran left, the parents that came to speak, was that he said that I saw a little girl shot to death. I did nothing. I saw three people staring at me, and through their eyes, I did nothing. I just watched. This is what he's going through, and he has to come home and be normal. Okay, so if you can kind of look at them, I'm going to try to Exposed to single episode or sustained trauma. General population single episode trauma can have a significant impact, such as rape or the natural disaster, Katrina, and something can trigger, you know, that. I had someone told me that a veteran was at a hospital and the lady, her finger sent him way back. Natural supports are interrupted, you know, family supports are interrupted, children. Divorce rate of 50% in our general population. Vets are at risk while deployed because of the dual pressure of what's going on at home. They come back home, their wives are trying to help and understand. They can't tell their wives. Some of these vets told me, when I was on the phone with the guy, he said, I can't tell you, Mrs. Griffin, what I did. I can't even talk to my mother of what I did. You have no clue of what I've seen. You have no clue. I did so many things. I've seen so many things, and I can't tell anybody. Do you know what that's like? I will never forget those words. So now we're going to talk a little bit about myths and misinformation. Asking about suicide will plant the idea in a person's head. How many actually believe that? And believe it or not, there are some people that actually believe, you know, I'm not going to say it because if I say it, they're going to try to, I'm not even going to mention the word. I had someone at our VA, an actual provider, say, well, he didn't talk about it, and I didn't talk about it either. And I said, because you didn't talk about it, he attempted suicide yesterday, and now he's hospitalized. If you had just asked the question. Just ask the question. Asking about suicide does not create suicidal thoughts any more than asking about chest pain causes angina. This doesn't mean that somebody's going to attempt because you mentioned the word. There are talkers and there are doers. How many believe that? There are talkers and there are doers. These people just talk about suicide. They're never going to do nothing. They've been saying that for 10 years. And they're actually doers. Okay? The one veteran that actually killed herself, she had been talking about it for 10 years. 10 years. She finally did it. So at the time, they may appear to be talking, but they're getting a plan. She was at peace. I was on maternity leave when this happened, but they were telling me how at peace she was. She just knew she came to the VA to do it. Most people who die by suicide have communicated some intent, and I'll tell you about a story. This young man who he was at home preparing. His mom came home preparing for dinner. He had just been discharged from our partial hospital, and he did well, was doing well. He came home. His mom said, I'm going to prepare you some squash. That's your favorite meal. He's like, okay, Mom. Bob called or Mike called, and he's like, I'll be back. I'm going to go downstairs and wash my hands. I'll be back for dinner. Went downstairs. She heard a bang. Went downstairs. He blew his brains out. So I said, well, ma'am, I'm sorry for your loss on behalf of the VA. We always have to say that. But I said, there were some warning signs. There had to be. She's like, no. She said, the only thing he did was he went around and talked to she said, well, his best friend committed suicide at 16. And he helped his father clean up. And he just recently left the girlfriend. He killed himself over the girlfriend. She said he left his girlfriend's house. He was over there for 4 and 5 days in a row. And they were going to call the police because they thought he was harassing. What was he doing? He was asking for help. He was finalizing. He was saying his goodbyes. He did it the same way his best friend did it, right before dinner in the basement with a gun. 16 years old. Now, he was 48 when this occurred. He carried that with him. She said that he did call the VA and said he talked to one of the social workers because he was so happy that she helped him. So he wanted to call her and say hi. He was saying his goodbyes. He knew it. He knew it. They do communicate. It may not be the way you and I communicate, but in some way, shape, or form, they do communicate. If they want to die, there's nothing you can do about it. How many, there's nothing I could do about it, 4 in the morning and I'm listening to this guy, and I'm like, that sounds familiar. And it was him that they had written a story about. And what he said was that he went onto the bridge, and his whole thing was this. He said, if I get one smile, I'm not going to jump. He knew it in his heart. He's like, I am not going to jump. Just give me one smile. That's my sign to say I should still be here. No smile. He said he climbed up and jumped. And on his way down, he realized he did not want to die. He's like, Lord, help me, please. I don't want to die. Hit the water. He said, next thing you know, his rescue people were coming around him. He was half conscious. And as he came to after a couple of weeks, they said, you were survived by a sea lion. Kept him afloat. Floating around him, keeping him afloat so the currents would take him under. And he said, so wherever that sea lion is, thank you. I'm like, that's Jonah in the whale, But, and I was telling my people, I'm like, if God can use a sea lion, he can use you. Okay, this sea lion was just floating around him, keeping him up. floating around until help came, the sea lion disappeared. Isn't that amazing? And he just, you know, basically he couldn't see past his circumstances. A lot of people that commit suicide, they really just want to ease the pain. It's like those horses in a horse race. They have these blinders on. They can't see left or right. They can only see the pain, the suffering, and he was going through a lot. And so the acute risk for suicide is often time limited. You can help the person survive the immediate crisis and overcome the strong intent to die by suicide, okay? And so a lot of people, there is something you can do. A smile, a hello. That gentleman that was in the hallway, all I did was say, can I help you? Can I help you? That's all I asked. This is the assessment card that we developed for our ED and our primary care so that they now have a tool to use. So now that you see some of the risk factors, we're going to learn how to identify them. They don't walk around with a sign on their head telling them, I'm suicidal, help me. Okay, there's no single profile to recognize these individuals. So we need to know some of the signs and symptoms that they exhibit. And here's some of the signs and symptoms, as you saw in our high-risk criteria. Talking, or I'm just going to go through some of them. Rage, anger, seeking revenge. Give me an example of seeking revenge. We had a young man who said, Mrs. Griffin, I tried to kill myself because she left me for another man, and she was going to feel bad if I had died. I said, well, how would you know? How would you know? You know, you'd be dead. He was like, you know, I didn't think about it. But again, they only see this. They don't see anything else. He's doing fine now, but increased drugs or substance abuse, giving away possessions, decrease or increase in sleep and spirituality. Now, how many of you are actually comfortable with asking the question, after you've seen these signs and symptoms, how many are comfortable asking, are you suicidal? A lot of people aren't comfortable with that because now we're dealing with the task of, oh my gosh. You know, if I came to, like, I always come to them, I'm like, if I tell you, know, my name is Mrs. Griffin, and yesterday I put a gun to my head, when I go home I'm going to kill myself, so what can you do? We don't be like, hold on. And that's what a lot of us do. We're like, hold on one second, I need some help. And we lose all kind of clinical training and we lose everything because now we're like, what do we do? And so we need to find out, how do we ask this question? We had a veteran on our unit, and when he finally exposed to his parents that he attempted suicide was the reason for his hospitalization, his father said, what? I can't believe it. And his father was a Vietnam veteran. That veteran just shut down, completely shut down. He was the one who said he wanted to go back and kill some more. He shut down. It was hard to engage with him. But you don't want to ask it as if you're looking for the no question. You're not going to kill yourself, are you? Oh, good. Ooh. Oh, okay, next. You know, you don't want to be rude and just talk about, okay, your name, your date of birth, you're going to kill yourself? Okay, good. Okay. You know, you don't want to just ask it like that. You don't want to ask it in amazement, okay? After you have a reasonable enough of information to believe that the veteran is suicidal, you see the risk factors, you see the warning signs, a recent returning veteran, okay, at an appropriate time, and in a way that it flows with the natural flow of the conversation. You know, Mr. Such and Such, I know a lot of people, you know, that are sad and depressed and are losing their home. They often talked about killing themselves. Have you ever thought about that? So it flows in with your conversation. You're not just blurting that question out. So we have to also consider, you know, some things, you know, remaining calm and listen more than you speak and limit your question and be honest. This one guy said, Miss Griffin, because you was honest and open with me, I'm not going to kill myself. You also saved my life and somebody else's. I was like, who is that other person? Because that's a criminal matter. You need to go down to the police station. Do I need to make a criminal report? You know, but he was, and to this day, he calls me just to talk. He's no longer on the high-risk list. He said, you were the first person to help. Because when he came in, he said, you going to try to help me? I said, I don't know. That's up to you. I may not be able to help you. When you leave here, you may kill yourself. I don't know, but I can try to do my best. So I told him. He was like, I like that. I really like that. And so he suffered from migraine headaches to a point where it put him in a fetal position. They last for hours. So out of a 24-hour period, probably over half of that he was going through migraines. He tried to commit suicide several times. And I tell my staff, I'm like, don't tell them they're going to go down to the ER department and they're going to get seen right away. It may be a little wait. They may have some, ER is life or death. They may have a life or death situation come, you know, there, but don't tell them they're going to be seen right away. Don't tell them that. be honest. It may be a long wait, okay? It's a life and death in ER, so it may be a wait. Then again, you may not, wait long, okay? But at least let's go down there. So you want to validate that you are following what they're saying without supporting the suicide. Yeah, I can understand you losing your home. Your wife left you too. Your children don't want to, oh, I'll kill myself too. You don't want to validate the suicide, but you want to listen and validate how they feel. Let them know that you're there to help, or there's trained professionals here to help. And this is for my facility, but if you work in a facility, you should have a referral process for a veteran that comes in your department and says, I'm going to kill myself, I'm suicidal. You should have a warm transfer is what we call it. Okay, such and such, let me get some information from you. Sit down, and while you're sitting there, you can punch a button, that button light up. Somebody from another department comes over and say, you know what, we're here to help you. We're going to take you over here to our department. And have that warm transfer. If not, create a referral process within your facility. We have a few of them that I created, okay? And so it should be a warm transfer, although people are still, people are going to do what they're going to do. But set the stage. Tell them what to expect. And then last, we're going to talk about just briefly a safety plan. After these veterans come on our unit and they're treated, we have to now engage in a safety plan, okay? Safety plan is a list. This is now a mandatory tool. Believe it or not, the VA is just developing a safety plan. So, yay. But it's now a mandatory tool. It is part of our computerized patient record, the CPRS. It's part of that record. So when a veteran comes in to our inpatient unit before they're discharged, they have to have a safety plan. And they have to add me on as a signer so that I'll know that they're being discharged and there's a safety plan there. Okay, central office is monitoring all of this. And even if they're not hospitalized, I created the safety plan. It's a part of the template we use, and anybody can access it in primary care, in podiatry. It's just a list of questions that you ask, and anybody can ask those questions. You have a safety plan, and you give a copy to the veteran so that they can utilize that safety plan. So that's really important. It is one of the evidence-based practice, so we're going to talk about a safety plan. It's a list of coping strategies and resources that the patient can use. Patients are experts in their care. That's that solution focus that I learned in FIA. They are experts in their care, okay? And so they need to identify what their triggers are, what are their warning signs, who their support system is, okay? A safety plan is not a suicide contract, okay? The contract may serve to protect the situational therapist more than a patient. That's what the suicide contract for. You promised me you won't commit suicide, so now you've got a legal, and so it's really served for the therapist more than it is for the patient. There's no evidence to support suicide contracts. It's a brief, and it's in the veteran's own words. It's comprehensive risk assessment, and it's 6 steps that we use. Step 1, we talk about warning signs, and we need to ask them how will you know when to use this plan? And the veteran may say, well, you know what, normally, after my mother calls me, she makes me kind of upset. Look, this one veteran said, my wife causes me to be suicidal. How are you going to do a suicide? How are you going to do a safety plan with that? Okay. Well, sir, every time you wake up in the morning, you need to have your safety plan right next to you and review every day. But that was his trigger, he said. But what do you experience when you start to think about suicide or feel extremely distressed? The warning signs, okay, your thinking process, your mood and behavior, these are all in the veteran's own words. Number 2, internal coping strategy. What can you do on your own if you become suicidal again? And this is really developed so that we can prevent some of them from coming back and forth in the ER, kind of using it as a crutch, We would get veterans in the ER department 24 hours, 7 days a week just because I'm suicidal thoughts. Okay, well, you need to learn how to cope on your own, so let's find a way that we can do it. And if all else fails, this is open, 24 hours. How likely do you think you would be able to do this step in a time of crisis? And identify roadblocks, okay? Step 3, social contacts who may distract from the crisis. Instruct the patient to use this step if step 2 does not resolve the crisis. And what social settings help to take your mind off the problem for at least a little while. Ask for a safe place, maybe a coffee shop, maybe it's the library, you know, maybe it's just walking down the street, okay? Remember, in this step, suicidal thoughts and feelings are not revealed, okay? At my table, we have the same thing if you need to have this to develop a safety plan at your agency. At my table, we have these cards that you can use, and it goes through all these steps. Instruct patients to use step 4 if step 3 does not resolve. Who among your family or friends do you think you can contact? They may have a best friend or someone that they really use, okay? And you know, I can always count on Angela. I can always, my girlfriend tell me, I can always call you because you 3 o'clock in the morning, you be acting like you still up. I be not, I mean, you know, they call me and I'm like, oh yeah, I'm up. But they can call me because they know that I'm there for them. So who is there for them? Ask for several people in case one is not available. So you may have them, you know, put a list of people down. You know, give me 3 people at least. Your first person is always your first choice. And if they're not available, you have these other 2. And how would you be willing to contact these individuals? Okay. Step 5, professional and agencies to contact. On our safety plan, I put down for them already all the numbers they need, the 1-800 number, because I don't want them trying to look in their cell phone and may not have it anymore. They're trying to look for a number. It is on their safety plan. They got the numbers to Ann Arbor. They got the numbers to Detroit receiving. All the numbers are on there. So you just pull it out and all the numbers are on there right there. Yes, ma'am. Mm-hmm. Mm-hmm. And that's why it said at least 2 or 3 people. Yes. Mm-hmm. And you know, and again, with our veteran population, they are transient. So numbers, you know, they may have wrong numbers change, they may not be in constant contact with their family members, so with our veteran population, it changes all the time, and so we always tell them, give us an accurate number. Who's the most recent person you saw in the last week? You know, we always tell them, ask for the last week or 2, because they may not see that person again, and we call that number, it may be disconnected. I've had so many veterans call me, give me a number, and we call it, and the friend is no longer available because they're giving you other veterans. And if that's their support system, then you take that. But then that veteran is homeless or transient. And they may just have a cell phone, but they're moving and they're moving. So we ask them, give us someone who's been, you know, I tell them, go a step further. You know, don't be afraid to explore. Can you give me a name of someone who's been living in a home for at least a couple of months now that has a home number? You know, get that information. Go deeper. You know, at least have that information. Get more than just one number. List names and numbers of mental health professionals. You know, your therapist number, your psychiatrist number. I don't know if any VA provider is going to give you their number, but at least you'll have it. And we do have a 1-800 number at our VA system that we recreated, that I wanted to have our number internal, because what was happening is that on the weekends, holidays, and after hours, the number, they call that 1-800 number, and it goes into a queue in Toledo. Who knew how long they're going to be waiting to get picked up? All of our visiting goes to that after hours. It could have been a 30-second wait. That's a long time when someone's in crisis. So we develop a system where we have it now internally. So after our triage department ends at 4:30 Monday through Friday, they forward that number to our inpatient psych unit where we have our hotline. We call it our after-hour triage. And so if you call at 2 o'clock in the morning, our crisis number, it goes to our inpatient. So we have a trained psychiatrist there. The nurses are there. It's inpatient, so they're able to help right away. So they're no longer waiting in that queue. We got the 1-800 number. Okay, that's that number, again, I talked about first thing. Making the environment safe. Ask the patient which means they would consider using during a suicidal crisis. And identify ways to limit access. Like the young man was speaking, he tried to limit access. You take the gun, I take the bullets, or vice versa. You know, ask them, do you have a weapon? Do you have what kind of weapon is it? Do you have bullets? Where are the bullets? Is it close? Is it locked up? Is it in another home? I mean, most people, they just say, do you have a weapon? And they go, yes. And that's it. Every time I read these assessments, I'm like, where is the weapon? So now I have to call, sir, excuse me, you just had an evaluation here at our VA system. And it mentioned that you were suicidal, you're placed on a high-risk list, and it mentioned that you had a weapon. Can you tell me if you still have that weapon? Yes. Can you tell me where it is? Can you tell me if there's anyone else, little kid, you know? So now I got to gather more information. Now I got to convince him to get rid of this gun. Sometimes it's successful, sometimes it is. And I think one time I just said, you know what, sir, do you have a CCW? You know, he's like, no. I'm like, well, you're not supposed to have a weapon, I don't think, you know. And I really wasn't sure, but that was the only way because he had attempted before with the gun. It was a superficial wound. But I'm like, I don't know what to do. And so he ended up calling his daughter, and his daughter got on the phone with me, and she said she's taking the gun. I was really happy about that. And she still has it to this day. So it was good. Now, I don't remember if that was, I'm like, CCW, is that true? Can you have it in your home? You know what I mean? So I was like, I think you can have it in your home, you know, as long as you're not out in the streets carrying it. But it was innocent because at the time I really didn't know. So I'll say that. Access. Yes. Do you have access to a gun? Do you have access to any lethal weapon, you know? Restrictive veterans, for methods with a low lethality, ask the veteran to remove or restrict the access. Restricting the veteran's access to highly lethal methods should be done by a family friend or the police. And the next step is assess for the likelihood that the plan will be used and problem solve any barriers or obstacles to using the plan. And where would this be located in case of a crisis? Evaluate that the safety plan is appropriate for the veteran's capacity and circumstances, okay? Make sure that the veteran A can read. You know, sir, can you read your safety plan? Because some of them may not be able to read. Do you understand your safety plan? Do you know how to implement it at the time of crisis? A safety plan is only one part of a comprehensive suicide care plan, and it's collaborative effort between the veteran and the clinician, okay? And yeah, I did good. You nodded your head. And if you are in an emotional crisis, call the VA hotline. And I am doing great. It is 2:15. And this is our information if you need to contact us at the John D. Dingle VA Medical Center. If there's a veteran in your area that has attempted suicide or even completed suicide, we need to make sure that we report on that so that we can keep our accurate statistics so that you can listen to the VA and not the media. Now, do I have any questions? Again, before I answer your questions, the one thing I will say is the VA system is very much fragmented. So that means that we have certain things in certain departments. Okay, so if you're talking about benefits, I'm not a benefits specialist. Okay, we do have a department for that. I do know a little bit about it, but I'm not specialized in that. So there may be questions that I can't answer about benefits. We had a benefit book out here that I brought, but they're all gone. So I'm assuming everybody had questions on benefits. Okay, so I just want to tell you that it is fragmented, so there's certain questions that I may not be able to answer, but we'll try. Go ahead, sir. I'm sorry.
Okay, I'm not a veteran, but my brother is a Vietnam veteran. He's been diagnosed with post-traumatic stress syndrome, and also he's a substance use user, drug user. And I'm wondering, is there a correlation or study between PTSD, substance use, and maybe suicide? Is there a relationship there? Because he continues to believe in at-risk behavior.
Yes, remember 80 to 90% of people have a mental illness, and PTSD is considered, you know, a diagnosable disorder. It's a mental illness, and there is very much a correlation. Because of the effects of PTSD, most of them get withdrawn. They go through that hypervigilant stage. They go through crisis and emotional barriers and withdrawn. When they come to our department, we do have a PTSD clinic, by the way. So if anybody has, we do have a PTSD clinic. I think it's somewhat new. I think it's been up and running for a couple of years now. And it's ran by a team of individuals who assess for PTSD and then treat accordingly. But yes, there is very much a correlation with that. And there's constant studies on it when they come back. with PTSD, depression, bipolar, major depression, all of that correlates with, and it falls up under the umbrella of mental illness. We consider that a mental illness. Yes?
How long is the wait? If I send somebody over there, to start treatment, how long is the wait?
For which type of treatment? We have different clinics.
They're having a crisis, but they're not suicidal. Now you said you got 24-hour ER right now.
Yeah.
Yeah. How long is the wait to actually start seeing someone if they've had a history, but they're not, suicidal right this moment?
Some of them may have a provider assigned already, but it depends on the wait. I tell people to come in through our walk-in clinic. We have a walk-in mental health clinic. And when you come in through that walk-in mental health clinic, you can be seen that day. However, if you decide, okay, I'm not in immediate crisis, but I need to have, some appointments, it may be a week before you get an intake appointment. It may be a little longer, but an average about a week and a half for an intake appointment.
For crisis, do you look at crisis when you're receiving crisis? They have to be basically suicidal, out of touch with reality, or something, or they supposed to what?
If I do what?
You look at, they have to be, like, have a psychotic reaction, out of touch with reality, suicidal, to be considered for walking right in.
No. You can walk in right in and say, I just need to know when my next appointment is.
No, I mean, like, say the guy, we get so many people that are trained to, they all know our number.
Thank you.
They call 911, they come through to us. And they know not to say they're suicidal because they don't want to be checked. But they're saying, I really got to talk to you. I don't think I can make it. Are you suicidal? No, I didn't say that. So, you're not sure, but they're saying, I need to see someone right now. Is that good enough criteria? If they don't say they're suicidal, we still see them.
Yes.
And do they have to have ID?
No, if they've been to the VA system, then they have to go through our registration department to get registered.
Okay, during business hours?
During business hours.
Okay.
After hours, they still have a process where they can be seen in our urgent care, or ER, I'm so used to saying urgent care, our ER department, and then they can be registered at a later date. But they can still be seen right then and there. Even without ID. All they have to do is give them their name and last four of your social. I didn't hear you. Oh, sure. Sure.
And is there any difference if they're service connected? I know when I went to the VA, it was different if they were service connected or not. Most of my clients are not service.
No, we have at the VA service connection or non-service connected. And it can become extremely complicated to learn what service connection is and what isn't service connection. But basically, it's a service connected related injury. And so you may receive services for that particular injury, with no pay or no cost for a reasonable amount of time without having to pay for that particular, like say for instance, mental health or something. People come in for mental health, they may have been diagnosed with, PTSD. Well, they can come into our PTSD clinic and get services because they have a service-related injury. Okay, so that's what he means by service connection. No, but we cannot accept veterans with a dishonorable discharge.
Now, say they have substance abuse and depression, but they did 2 years in Germany and they're 16, so they got nothing on their medical record. So they're not even trying to say it's service connected. Do you still see them as far as counseling?
They will still see them, and then they'll have their, what we call it, DD 214 and all that, and they'll look up under that, but yes.
Okay, none of these guys will have a DD 214, but you can look it up, right?
They can look it up. I won't be, but somebody else will, yeah. If they are currently active duty, there's a suicide prevention coordinator that I communicate and let them know that one of your service, one of your veterans is here at our hospital. He's currently an active duty veteran. He will come and assess them. We'll also assess them, and we can flag their chart if they have the need for a flag. It doesn't matter if they're it doesn't matter if they're active duty or non-active duty or reserve. We can still flag their chart. But again, remember the flag is only seen within our vision, okay? So if they go somewhere else, North Carolina, it won't be seen. But they still have, you still can bury it, look at it under a note and find out if they actually have one, but they won't see it when they open up the chart. Yes?
Just a comment on that. There's a difference from Title 10 to Title 32. A lot of times the full-time Army doesn't communicate or transfer files from Title 10 to Title 32, so a lot of those records are gone.
Mm-hmm.
As far as those communication too, that because of the HIPAA requirements,
Yes.
communication, we don't receive a lot of that communication we follow up that probably should.
Yes.
On the people that have that ideology.
Well, they just gave us access later last year, to the Department of Defense records. Just gave us that access. So I'm able to go under that website and obtain some records if I need to. I've never done it, so I'm pretty sure there's a HIPAA, if you're accessing this record, because when you access a record that have a specialty flag on it, sometimes there's a little box that pop up. You are accessing this record and so on and so forth, and they know who you are accessing that record. So a lot of people wanted to access the record of the young lady that committed suicide on our grounds, and they were afraid to, because somebody could come to your office and say, why were you accessing her record? I mean, what was the purpose? She's never been in your clinic, and so you can actually get into some trouble for that. But we can access, and I don't know if there's that little disclaimer there or what.
That's a lot of the National Guard's problem. Is, we display, we formed a partnership with the VA, but it seems like a one-way street in which we don't get feedback on the ideology and risk factors, and yet we're transferring soldiers over.
Well, now you do. I mean,
but now the feedback has to come. Like you mentioned that you communicated with the prevention manager on the full-time side. Well, what about the states? Because each state will have one suicide prevention, and their task is to track those trends. And this is a perfect tool for us to assess some of these programs.
very much.
A lot of your units, I can tell exactly. There's a lot of these soldiers coming in from certain types of mainly infantry or younger soldiers.
Yeah. And, this was the second time that we're having our conference. Last year was the first time the Department of Defense and the VA with the coordinators actually met and communicated at a conference. So this year, we're having it again in January, so it's going to be an annual conference, and so the communication is beginning to open up a lot more. But there was very much, when I first got to the VA, not from the VA system, but I had learned that the communication was very, very limited. And collaboration was extremely limited. And so getting to know some of the people at the Sulphridge Air Force Base, because you have social workers and prevention coordinators there, we don't even know who they are, and we're just now really branching out. And so the VA is now trying to branch out a little bit more to get involved. And I was so excited to meet Sergeant Horton, and he didn't come to my last thing, but it was nice to be able to meet him, and of course I just met him now. So, so we're beginning to collaborate, and it's just really getting to know the resources and referrals and so on and so forth. Yes, ma'am.
How much work is done for the families of the veterans,
Well, the families can receive services through the VA, like wives can receive treatment or counseling or so on and so forth through the VA. Over the age of 18, because we don't do children because of the VA, but over the age of 18, if they need counseling, then we can do family counseling. As far as my program is concerned, with suicide prevention, we are strictly for the veterans. Now, if they do have a loved one that is at risk, I can refer them to other agencies, and that's where your collaboration with me comes into hand. Okay, well, ma'am, we do, because I can't flag her chart because she's not a veteran, and I can't, make phone, because I can't do that. So we can collaborate with the community and say, we have a veteran, a family member of a veteran who needs some services in your area or your department, and so we can refer you to them. They can receive counseling at our VA, but as far as having their chart flagged and doing a safety plan, because all that's part of a record, if they're not a veteran, then there's nothing that our department can do.
If I could just make a comment on that. We just contracted out military family life consultants.
Okay, good. See? Yes, sir.
Just a simple question.
Operation Enduring Freedom, Operation Iraqi Freedom. Yes, sir. I can't hear you. I'm sorry.
What kind of screening are they doing when they're coming back from Afghanistan, Iraq?
We do our post-deployment screening. Remember I said we go to the Air Force, we go to Selfridge.
Coming back, being back, being screened,
Yes,
PSDS.
yes, yes. And all our visits, all of the ones, we had 203 of them return sometime in, Beth just walked in. This is our case manager for the program. And I think it was, I was off, but I think it was in March or April. And we had Battle Creek was there, Indianapolis was there, and some of the people from Detroit were there because we may have had some people that were in our area that needed to be screened. So we have our PHQ-9, our positive depression screen, and PTSD screen, which will prompt a suicide screen. And so they'll be assessed for that. And they'll be referred to us if they come up positive, and be referred to mental health, as well as PTSD, as well as our comp and pension for compensation, and so on and so forth. So yes.
I don't know what they're doing now, but back in 2005,
2005.
when my 47-year-old baby came back from Iraq, they had the husbands and wives to go out to Fort Lauderdale for almost a week. When they had been back about 3 months, and then they continued to check for a year and a half to see
Okay.
how things were going.
Okay. I don't believe they.
The problem her husband had is that she was in a drug addict,
Okay.
and her thing was, I can't pay $2 not just for gas, but I can get
Yes. Yes. I'm going to briefly, I think we're done, but I'm going to just briefly play this video. Everybody remember Gary Sinise, and then if there's another question, I think I have a few more minutes.
I'm Gary Sinise. You may know me as Lieutenant Dan from the movie Forrest Gump, or as the bass player in the Lieutenant Dan Band. I've had the honor to meet many of our soldiers and veterans. It's a sad fact that some of our warriors, some of our nation's finest citizens, are wasting their lives through suicide. Suicide is not the answer. It's final. It robs you of your chances for a better life and brings pain and heartbreak to your loved ones. You don't have to go it alone. VA cares about you. VA is reaching out to veterans who are thinking about suicide. So reach back now. Don't wait. Call 1-800-273-TALK and press 1. Our counselors will not share your information with anyone. Thousands of veterans have had the courage to call. How about you? Call 1-800-273-TALK and press 1.
Okay. Did we have? I thought I saw one hand. I'm sorry.
I'm Gary Sinise.
Oh.
It's a sad fact that some of our warriors, some of our nation's finest citizens, are wasting their lives through suicide. Suicide brings pain.
Thank you.
I may have misunderstood that. Did you say that VA has a team that will go out and pick up suicidal deaths?
No. What I said was that we have an OEF outreach worker who goes out to the community and or to the homes of the veterans. She will screen them right there and provide services to them. Yes.